Welcome to The Explainer. Today we're jumping right into the microscopic battleground of the kidney's ultimate barrier. We're talking about a filter that's working inside you right at this very second. We are exploring one of the absolute most critical and honestly most complex structures in the human body, the glomerulus. And more specifically, we're going to look at what happens when it's under attack.
So we have to start by asking a pretty fundamental question here. What actually occurs when the glomerulus, which normally acts as this elite biological bouncer keeping your vital proteins and red blood cells safely tucked inside your blood vessels, just completely fails? Well, the consequences are system-wide, they're fascinating, and they can be incredibly life-threatening.
Here is our roadmap for today's explainer. We're navigating the heavy hitters of glomerular disease. First, the glomerular barrier fails. 2. Nephrotic syndrome, protein loss. 3. Nephritic syndrome, cellular destruction. 4. Dangerous clinical complications. 5. Solving the diagnostic puzzle. And finally, 6. Targeted glomerular treatments. Let's get into it.
Okay, kicking things off with Section 1, the glomerular barrier fails.
To truly grasp the pathology, we've got to look at the healthy baseline architecture of our filter. Now, the glomerular basement membrane is naturally negatively charged. And since your plasma proteins are also negatively charged, this membrane essentially acts like a magnet, pushing them away, repelling them right back into the blood. Now, sitting on top of this membrane is the visceral layer, which is made up of these completely unique cells called podocytes. These podocytes have tiny little foot processes with slit diaphragms. Think of them as a microscopic mesh trap that physically catches large molecules. So when this barrier gets injured, whether you lose that negative charge or those podocytes take a hit, you lose both your repulsive factor and your physical trap. The result? A massive microscopic leak of proteins straight into your urine.
Now, there is one magic number you absolutely have to lock in here, and that's 3.5 grams. Losing more than 3.5 grams of protein a day marks the definitive entry into the nephrotic range. This isn't just some arbitrary cutoff either. It literally represents the tipping point where your liver simply cannot compensate for the protein loss anymore, and that's what triggers a whole cascade of clinical symptoms.
Which brings us nicely to Section 2, nephrotic syndrome, protein loss.
This is the first major bucket in our dichotomy, defined by heavy protein loss, podocyte damage, and crucially, no hematuria, no blood in the urine. The easiest way to break this down is by categorizing the causes into primary disorders that attack the glomerulus directly and systemic illnesses that affect the entire body. Looking at the primary side, we have minimal change disease, which is the most common culprit in kids. It's driven by cytokines causing podocyte effacement, meaning those foot processes just flatten out and lose their shape entirely. Then you've got focal segmental glomerulosclerosis, or FSGS, mostly seen in adults, involving severe scarring that can be triggered by things like HIV. There's also membranous nephropathy, where immune complexes deposit right under the podocytes. Now, flip over to the systemic side. We've got diabetic nephropathy, where chronic high blood sugar actually causes nodular scarring, those classic Kimmel-Steele-Wilson nodules. And finally, amyloid nephropathy, where misfolded proteins from diseases like multiple myeloma just jam themselves directly into the kidney filter.
All right, let's flip the coin. Section 3, nephritic syndrome, cellular destruction.
Let's put these two side by side because the contrast is stark. If nephrotic syndrome is a leaky sieve losing its charge, nephritic syndrome is violently destructive. It's driven by intense inflammation that punches literal holes straight through the basement membrane. I mean, these holes are big enough that actual red blood cells escape into the urine, which gives us that hallmark hematuria. And because the physical damage is just so severe here, the overall filtration rate drops. So counterintuitively, you generally leak a more moderate amount of protein, typically staying under that 3.5 grams a day threshold.
Nephritic syndrome can feel like total chaos, but categorizing it by its underlying mechanism makes identifying the specific disease way easier. It could be direct antibodies, right? Like an anti-GBM disease or Goodpasture syndrome. And remember, Goodpasture hits the lungs too, causing patients to cough up blood. Then you have ANCA-mediated vasculitis, where neutrophils go rogue and cause the damage. Or we see immune complex deposition, which heavily consumes your body's C3 complement proteins, basically your immune system's alarm bells to drive that inflammation. Classic examples of this are post-strep glomerulonephritis and lupus nephritis. And finally, the mechanism could be purely genetic. Take Alport syndrome, where a mutation in type 4 collagen leaves the membrane physically weak, and it's often accompanied by deafness and visual issues.
Moving right along to Section 4, dangerous clinical complications. Because these two barrier failures leak completely different vital components out of your blood, the systemic fallout is incredibly specific to the syndrome. In nephrotic syndrome, you are losing massive amounts of albumin. Without albumin holding water inside your blood vessels via oncotic pressure, that fluid just leaks out into the tissues. We're talking profound severe edema around the eyes, the belly, the legs. In response, your liver absolutely panics and tries to churn out more proteins, but inadvertently pumps out excess cholesterol, giving you hyperlipidemia. The cascade doesn't stop there. You lose anti-clotting proteins like antithrombin 3, which skyrockets your risk for deep vein thrombosis, pulmonary emboli, or even renal vein thrombosis. Oh, and you're also peeing out immunoglobulins, leaving you wide open to severe infections.
Now, on the flip side, the literal destruction happening in nephritic syndrome causes the kidney's filtration rate to absolutely plummet. The kidneys sense this drop in flow, they panic, and they start pumping out a hormone called renin. This triggers a massive cascade that spikes blood pressure. So severe hypertension is practically a required feature for a nephritic diagnosis. But the scariest part? This intense inflammation can cause the cells encapsulating the glomerulus to multiply rapidly, forming a physical crescent that just crushes the filter entirely. We call that rapidly progressive glomerulonephritis, or RPGN.
All right, let's play detective. Section 5, Solving the Diagnostic Puzzle. Because these symptoms overlap so much, clinicians really have to use a careful, step-by-step approach. You start simple, a urine protein-creatinine ratio, to see if we've crossed that golden 3.5 gram threshold. Then, you look at the urine under a microscope. Finding fatty casts? That points to nephrotic. But if you see dysmorphic red blood cells or red blood cell casts, which are literal microscopic molds of the kidney tubes, that is a massive red flag for nephrotic syndrome. Next up is targeted serology, checking the blood for ANCA, C3 consumption, or specific antibodies. But to truly nail down the diagnosis, you need the ultimate judge, the renal biopsy. This is where it gets really cool, because a biopsy reveals these breathtaking microscopic clues. With minimal change disease, regular light microscopes show absolutely nothing. It looks perfectly healthy. You actually need an electron microscope to see the flattened effaced podocytes. Other diseases leave totally distinct signatures. Membranoproliferative disease shows this classic tram track sign as cells interpose through the membrane. Immunofluorescence is a game changer here. Seeing a smooth, linear glow immediately points to good pasture, while a spotted, granular glow points to lupus or post-strep. If it doesn't glow at all, what we call pausiimmune, that points straight to ANCA vasculitis. And amyloidosis? It reveals something truly incredible under polarized light. A stunning apple-green glow known as biofringence when you stain it with Congo red. Finally, let's talk about how we fix this. Section 6, Targeted Glomerular Treatments. Treatments really scale from managing basic symptoms all the way up to heavy-hitting root-cause immune suppression. We use sodium restriction and loop diuretics to physically pull that edema fluid off the body. ACE inhibitors are absolutely brilliant here because they vasodilate the exit vessel of the glomerulus. That drops the pressure inside the filter and immediately reduces protein loss. Statins help manage the cholesterol spikes, but to stop the actual disease at its core, we bring in corticosteroids for things like minimal change disease or really powerful immunosuppressants like cyclophosphamide to shut down those rogue antibodies in other primary diseases. And if the destruction is just too rapid, dialysis steps in to replace the kidney's function entirely. But what about emergencies? For rapid, severe attacks, like the ones causing RPGN in Goodpasture syndrome, standard meds just aren't fast enough. Enter plasmapheresis. Think of this like an emergency oil change for your blood. It acts as a total reset. We physically take the patient's blood out of their body, separate and pull the attacking antibodies away, and pump the clean blood back in to instantly halt the destruction. So as we wrap up this explainer, I want you to consider how these massive systemic failures all begin with just a microscopic shift in charge, or a tiny little hole in a membrane. The difference between a full recovery and a life tied to a dialysis machine often comes down to early detection. Spotting those subtle systemic signs, the unexplained swelling around the eyes, the frothy urine, or that sudden stubborn spike in blood pressure is absolutely critical. Because when we understand the biology, we can act fast enough to protect the kidney's ultimate barrier. So what does this all mean for the future of early diagnostics?